In isopure, beyond this equation, you have a few additions. These few additions are actually for the free-form optics and the curvature changes that happen. However, the difference from the Vivinex Impress is this has it in the whole of the optic, and yet it does not produce any compromise with the quality of vision. How does it do it? This is how it does it. Both the surfaces are aspheric. Both the surfaces are complementary in design to one another, as you can see here. So there is this base curve of the IOL, then the curvature changes happen at the inflection points, but the inflection points are there on both the surfaces. So whatever convergence you need can be divided into half and half. The anterior surface does it 50%, the posterior surface does it 50%. So you do not have a gross change in the surface geometry. The quality of vision is not compromised with, yet the job is achieved. So the depth of focus of a 19.5 diopters IOL, for example, of Micropure, which is a monofocal IOL from the same company, will produce this much of depth of focus. For a 19.5 isopure will produce the depth of focus which is stretched out. However, the distant visual acuity in terms of logMAR mildly drops, in terms of MTF mildly drops, which is pretty much acceptable. The peaks of this IOL, again, the defocus is very, very consistent. What you achieve in one patient is what you can achieve in 100 patients. You can confidently pitch for that into the patient's minds. There is a material advantage. It's a hydrophobic IOL, and the water content, though, is slightly higher, but the performance is excellent post-operatively. It behaves much less rigid than the other hydrophobics in the market because the water content is slightly increased and also makes it glistening free, essentially. And the defocus is much better with larger pupils. So we just talked about the Impress here. When pupil enlarges in a photopic pupil, I'm not talking about a mesopic condition. In a photopic pupil, when you have a large pupillary condition in a photopic pupil, the Impress actually slightly underperforms because the peripheral girdle, which is dedicated for distance, actually comes into play. But the isopure, since it has these changes right throughout the optic, even if you have a larger photopic preoperative pupil, you can still go ahead and select this lens because this will perform exactly the way it should. Troughs are the toric trim. I'm not very sure about the design and the toric trim being available on this platform. The PCO profile is something that theoretically raises a question in your mind because the water content has increased. However, the user feedback from all around the world globally has said that it is performing beautifully, and I have more experience with the toric version, monofocal toric version coming from with the same platform, and it behaves absolutely fantastic. There's no PCO profile, and it sits in very well with the capsule indeed. But that's something that we need to keep in mind, and it needs to be studied as we implant more and more. This is the typical depth of focus curve. Look at this depth of focus. This is almost 1 diopter, and this is the average depth of focus that I've taken into account. In some patients, it actually exceeds 1. It goes into 1.13, and the distant visual acuity is also sharp. The peak is also sharp. Both of these IOLs can be combined into one. We'll just come back to that later. Impress and isopure, because they work on the same technology. And how do I choose my patients? Remember one thing, any lens that works on the free-form optics principle, the defocus will be much better when you have the myopic range of patients, when you have the IOL diopter less than 20. And the defocus drops when you go to the hyperopic range. This is also true for both of these IOLs. That's true. So when you see the IOL power that has been calculated, you can imagine how much is going to be roughly the depth of focus, and accordingly you can pitch to the patient. Both produce consistent defocus, as we saw. Peak of the VS-OTF curve of the Impress slightly edges past the isopure, but the isopure performs much better in large photopic pupils. Sorry for the typo. Large photopic pupils, as we just explained. Large capsular bags. If you have a myopic patient, the C-loop haptic performs slightly better, so the Impress performs slightly better. But if you have a hyperopic eye, if you have a small capsular bag, then the isopure exceeds the Impress in its performance. So we'll just come back to the previous slide. This is what is the crux of the enhanced monofocal IOLs and why they constitute a major part of my practice nowadays. This curve is known as the encircled energy function. What does it show? It shows, look at the cornea here, and I don't know whether it's visible to you or not, but can you see the 1 written over here? What it means is the cornea is allowing 99% of light energy to pass through. It is destroying only 1%, all right? And after the IL implantation, if you look at the total eyes encircled energy function, it shows 2 to you. What it means is, from the cornea to the IOL, when the light energy travels, the IOL per se is causing a decay of light only to the extent of 1%, which means 98 to 99% of the light energy is still available. This is something you can find only with enhanced monofocals. This is not something you're likely to find with trifocals, definitely not. And even with most of the EDOFs, some amount of, a good percentage of light energy is lost. The other aspect of enhanced monofocals is the point spread function. This is the rough and average point spread function of both of these IOLs, both the Impress, and I was talking about the Impress and the Isopure there. This is a typical PSF taken particularly from the Isopure. The Impress actually fuzzes out a little bit, but when you talk about, since it's present in the whole of the optics, this is the point spread function. Look at the tightly knit PSF that we have on the foveal point. You can imagine what the clarity of vision, what the quality of vision is going to be. It's going to be very sharp on the image point of view, from the image point of view, and it's forming a deadly knit, closely knit conglomeration of light energy at the center of the fovea. So these were some of the IOLs and their principles. Thank you so much for the opportunity, Sheetal.
Thank you so much, Dr. Anurag, for breaking down such a complex topic, explaining the principles and the technologies. So, any questions for Dr. Anurag? Yes, please.
Need to measure the angle kappa always before implanting any EDOF? Or if you don't have the facility to measure the angle kappa, which lens would you prefer?
No, kappa is actually not that important, but the alpha is in choosing IOL. And if you're not implanting a monofocal, if you're going beyond that, be it an EM, be it an EDOF, be it a tri, the alpha should be measured. I do not buy the the proposition that is put forward by many authorities that angle alpha is not important, because I've got evidence and loads of it to prove that angle alpha is very, very important. I'll just give you an example. When the VVT was launched, and it's still said to be a universal IOL, almost every patient can receive it. Wrong concept. The VVT is more sensitive to decentration. If you're putting it in a perfect patient who should receive it, the results are fantastic, phenomenal. But if you're not putting it in a patient if you're putting it in a patient in which the alpha is more, and it's likely to be decentered in the central zone, the central surface change is shifted a little coronally, then the results are devastating. So if you can, you should. And if you do not have access to, as you pointed out, to a machine that measures the angle alpha, because iTrace is the only equipment that measures the angle alpha, then I believe you should get it done in another center which has access to it close by to your practice. But I believe it's always a better idea to see that before you plan any such IOL. That's not a monofocal.
Can we put these lenses in diabetics and patients with glaucoma?
Absolutely. These are, from those senses, from comorbidities, ocular or systemic comorbidities, these are universal IOLs. If the condition of the optics, the light path passing through the eye, if there's any aberration in there, you will think. But comorbidities do not pose as a contraindication. Yes, sir.
The Johnson & Johnson launched another lens, which they Pure C. So how does it differ from the Eyehance lens?
That's a question I asked them too.
Yeah.
To me, to me, structure-wise, the Pure C differs from the Eyehance in two aspects. One, the refractive change in the Pure C is in the posterior surface. The Eyehance has it on the anterior surface. Two, the refractive change in the Eyehance is located in the central 1 millimeters. In the Pure C, it is stretching to 3.5 millimeters. Apart from that, both of them, as far as the design factor is concerned, are almost similar. There's hardly any difference. But the defocus that is produced with the pure C is slightly better
Hello?
because the curvature change is more steep on the posterior surface. So we will discuss that, we can discuss that at length later on, but it adds both spherical, positive spherical and negative spherical aberration to the system of the eye. And that's how it produces the defocus and shifts it back to the foveal plane. The pure C is a lens which is very, very largely pupil dependent. You will not get the same defocus in all pupillary sizes. When the pupillary size goes up from 3.5 to 5 millimeters, the defocus substantially drops down. So it's not very consistent in producing the defocus if the pupillary size is not behaving properly, obediently. The cost difference is huge, obviously, because that's pitched as an EDOF, a proper EDOF. This is pitched as an enhanced monofocal. So the cost difference is, the one thing that has come with the Pure C, which was not there with their earlier products, is the preloaded assembly. Johnson & Johnson has really worked on that aspect, and the preloaded assembly of the Pure C is magnificent. That is one thing that where they have really worked hard, and they've really made it well. Can't hear you, sorry.
Is the pupil size important? Like in case of Vivinex Impress, it is there in the central 2 mm. So if a patient has a pupil size which is approximately 2 mm, so the distance vision will get compromised there in those patients.
To my experience, the Vivinex Impress acts pretty well till the photopic pupil stretches to around 3.5 millimeters. But beyond that, if the photopic pupil is dilated more than that, and somebody is trying to say, read something under low light, then he would not be able to. Even if it's kept at 66 centimeters, he would not be able to. So that's where it underperforms. That's where the ISOPIO scores.
Have you any experience in using these lenses in post-LASIK eyes?
Yeah,
Do you use them?
Yeah, that's a very good
regularly?
question. Actually, yes, I have. And in post, all refractive surgery, while LASIK only, all refractive surgeries, if you do not have much of corneal aberrations generating from the laser procedure,
Yeah.
then they work very well.